What about urinary incontinence? I would tell you that this is your common example of a chronic urinary tract problem that we see mostly in women, but loads of men have it as well. The numbers in the United States go like this. About 1 in every 21 people has urinary incontinence. What does that mean? That means several people in this room have it, and I'm not one of them. So what I would tell you is, how many people are going to graduate in the next 6 months? Raise your hand. All right, you see the hands that went up. Suppose I said, hey, raise your hand if you have urinary incontinence. Now you know nobody's even going to make eye contact with me. So urinary incontinence is not one of those things that people are anxious to tell you they have. You have to be gentle when you ask about it, but ask because it's extremely common, especially in women. And so, look at the different types of incontinence. We have urge incontinence. You know those people, right? You get in the car with them. 20 minutes down the road, what do they say? Gotta go, gotta go, gotta go. You know the gotta go commercial? What drug is that for? Detrol or Ditropan, one of them. It's for urge incontinence, right? That's one form of incontinence. Another is stress incontinence, which means there's incompetent sphincters. What happens with that one? That's where people laugh, cough, sneeze. They have a loss of urine. But the most common form of incontinence, according to the American Urological Association, is mixed incontinence, which means they have a little urge, a little stress, and a little something else we don't have a name for yet. So mixed incontinence is what most people have, men and women. So how do we help these poor people? Well, regardless of the type of incontinence they have, the recommendation for lifestyle modifications tend to be these. We want them to limit or avoid alcohol. That will always increase their symptoms. How come? Because when you consume alcohol, it inhibits your ability to produce antidiuretic hormone. Antidiuretic hormone, ADH, is what keeps you from urinating every drop of fluid out of every cell in your body. So that impairment of ADH when you consume alcohol certainly will increase your symptoms, as it will with carbonated beverages and lots of tea or coffee, all right, either with or without caffeine. So we try to get them to slow down on those or eliminate them. But behavioral therapy is where the crux of the matter is, and believe it or not, you can get significant improvement in patients with weight loss, especially if the underlying problem is stress incontinence. So stress that with your patients because certainly you'll find that it helps. The other thing that absolutely helps, regardless of the type of incontinence you have, is frequent voiding. How often is frequent? Well, for some people it may be every 4 hours, but for others it may be every 2 hours. The patient will figure that one out pretty quickly, but frequent voiding is a big deal. On your exam, they are all about Kegel exercises. You got it? So what about Kegels? This is generally how often people do them, and they try to get them to hold it for 6 to 8 seconds. And if they ask you about an intervention on your exam, you tell them, oh, it's all about Kegel exercises. Now, I have friends who work in urogynecology. This is what they tell me. Amelie, we have patients who do like hundreds of these a day. They all end up with surgery. They end up with a procedure. They end up with something. So I would just tell you that I guess Kegels work for certain people, but once you reach a point, you can do all the Kegels in the world, but it's not going to help your symptoms. So anyway, this is behavioral therapy. I would focus on these interventions, especially on my exam, but honestly, they're helpful in practice as well. And so are these. Maybe it's use of incontinence pads. Maybe. Is this a patient that you would want to put HCTZ on for their blood pressure? No. So consider and just use some good common sense as to what you might use for helping these patients. Excuse me. So here's your next patient. A patient with a history of kidney stone presents to your office. He's got intermittent pain that's rated 4 out of 10, but now has become a 9 out of 10. So it has increased significantly. What describes his demeanor in the exam room? When a patient presents with a kidney stone, what do they look like? Is this somebody who can't stop moving around the room? Oh, I don't think so. He's not pacing around the room. I think he's lying on the exam table rolling from side to side. He's not somebody who's afraid to move. He's someone who can't keep from moving because it's so painful. He might be nauseated, but typically he's not sitting in the chair holding a trash can. That's not your typical kidney stone patient. But number 2 certainly is, so circle that one. What are you going to do when these patients walk into your clinic? Because sometimes they do. You got to get them to the ER, but don't let them drive. And unless there's a contraindication, you may consider a Toradol injection with a call to the ER to let them know who's coming. But listen, when this patient gets to the ER, he's not an emergency. A gunshot wound to the chest is an emergency. An MI is an emergency. There are loads of people that take precedence over these poor people. And so I would tell you, a Toradol injection may take the edge off until they can get in the back and get something to help their symptoms. Everybody good? Let's talk about hematuria, because this is a big deal. 85% of bladder cancer presents with hematuria. When you look at a specimen like this, you should say this is gross hematuria. Gross means you can see it with the naked eye. But sometimes bladder cancer or kidney cancer can present with microscopic hematuria, and that is an early symptom. And when I told you when a patient had a UTI that you bring them back to make sure blood clears after the UTI, it is because you are concerned about this, hematuria. And so what can cause it? Look at the first bullet. It's malignant neoplasms in the kidney and or the bladder. That is why hematuria has got to be a red flag for you when you see it. But look at these other things that certainly can produce hematuria. And I want to know, the third to last bullet, what medications can produce it? Aspirin, NSAIDs, Pradaxa, Effiant. There are loads of medications that can produce blood in the urine. When the medication stops, the blood better stop. Otherwise, this patient needs a workup from urology, right? Blood never belongs in the urine. These are risk factors for malignancy in the urinary tract. Certainly age greater than 40. People who actively smoke are at some of the highest rates. But again, loads of risk factors, and that's why, because it's pretty darn common, you got to be all over blood that occurs in the urine. That is never, ever normal. So what's your job? Unless you can figure out exactly why the blood is in there, you've been able to remove what caused it and the urine stopped, you're going to have to get this patient referred to urology. Let's talk about kidney issues. You ready? Acute pyelonephritis is like a big old deal. It's a big old deal because it represents an infection in the upper renal parenchyma, and it's not just in the bladder. It is in the ureters or in a kidney in the upper areas. And look at the risk factors. The number one risk factor for pyelonephritis is an untreated or undertreated UTI. It's people who had a UTI and didn't finish their antibiotic. They took it for a day and a half and they stopped because they felt better. You know who else is on that list? Patients pregnant. If you take care of pregnant patients, you've seen pyelonephritis. So take a look. What might differentiate pyelonephritis and urinary tract infection? Like, what would let you know? I would tell you that something that really would help differentiate it certainly is the finding of pyuria, or pus in the urine. That doesn't occur with the urinary tract infection. It is way more common with with pyelonephritis. Even CVA tenderness that we typically associate with pyelonephritis doesn't necessarily differentiate, because you'll have people with UTIs who have CVA tenderness. But anyway, the finding of pyuria, that's not a bladder infection, that's a kidney infection. This is CVA tenderness, and I always remind people, when you check for this, make certain that you never use your elbow as a fulcrum. When you check for CVA tenderness in a patient, you use your wrist as a fulcrum. If they really have CVA tenderness and you do that, you do that using your elbow, your waiting room will empty. Because the patient you just hit like this is going to have blood-curdling screams. And listen, when people are waiting in your waiting room and there are these blood-curdling screams coming from behind the door, they look at each other and say, they warned us about these nurse practitioners. I'm out of here while there's still time. All right? So don't do that. I wish I had time to tell you how I know. All right. So what antibiotic are you going to give? When you suspect or you know the patient's got pyelo, you can look at every learned authority and guideline. Look at this. Quinolones are the only antimicrobials recommended for outpatient empiric treatment. You got to get them on something with a good degree of kill. If they can't take a quinolone because maybe they're pregnant, certainly you can consider something like an Augmentin plus ceftriaxone, but you almost always have to consider admission. People get septic with pyelonephritis and they can die. And I can think of at least 2 patients who've died with pyelonephritis that I've taken care of. One of them was pregnant, all right? And thankfully, they were not my patients when they died. So I would just tell you, watch out for pyelo. It's a big deal. And last point I forgot to mention, before you start an antibiotic with pyelo, you must get a urine specimen for a culture, right? You can't treat this one empirically, which means your best guess. What about measures of kidney function? How do you know if a kidney is functioning well or not? Well, there's several ways that we have to evaluate kidney function. One of them is with the serum creatinine. And to be honest with you, in some patients, that'll give us a decent measure. But in other patients, it's a terrible way to measure kidney function. And here's what we know. Creatinine is related to muscle mass. So in people with very little muscle mass, like an emaciated little elderly patient, she may have a low serum creatinine, but she doesn't have very good renal function. In a bodybuilder with a load of muscle mass, they're going to have an elevated serum creatinine. It doesn't mean that they don't have good kidney function. So in people who are typically of normal muscle mass, following serum creatinines might be a decent way to measure their kidney function. All right. So one way to think about measurement of kidney function is by evaluating the patient's serum creatinine. But beware, because there's some pitfalls. Another way to measure kidney function might be with a creatinine clearance. In fact, the most accurate way is to collect urine over 24 hours. But honestly, have you had to do this? It's a major drag. Yeah. Right? Every time you urinate, it needs to go in that big old container. Like if you go grocery shopping at Walmart, what? You got to bring your jug with you, right? You're like going and I mean, come on. So it's a major drag. In lieu of a 24-hour urine, what else could you do before you jump to that one? I would tell you that you could consider a GFR. It also measures mils per minute. It can be used to estimate creatinine clearance. It's not perfect, but at least it's pretty good. What do you need to know about a GFR? It's estimated on most panels, and let me show you what you look for. As long as a GFR is greater than 60, the reason you should feel comforted is because it means that you can give them almost any drug and they'll be able to excrete it. Once the GFR drops below 60, for you as a prescriber, it means you're going to have to decrease how much drug you give them so they don't become nephrotoxic or toxic on whatever drug you're giving. And so, one thing that we watch for is a GFR greater than 60. It usually gives us a pretty good feeling. There's a fact that you need to remember, and it goes kind of like this one. Starting at age 30, most people lose about 1% of their kidney function every year. So at age 70, you've lost about 40% kidney function. And the 60% you have left typically will carry you through your lifespan, as long as your kidneys remain in good condition and they're not damaged by hypertension or diabetes or lupus or some other disease. So watch out for kidney function. It's something that you always must pay attention to when you give patients medications. And one of the things that you always need to know about the medications you give is whether or not there's renal dosage, whether you got to change how much you give it. You give it every other day. You give a reduced amount. So anyway, be alert to that one. Before we finish with kidneys, I need to make sure that you know what you should be very concerned about. Here is your patient. A patient complains of fever and has dark urine. The urine specimen is sent to the laboratory, and here's what comes back. Blood is positive. Protein is positive. Nitrites and glucose are negative. And at the bottom of the report, it says there are white blood cell casts present. My first question to you is, do you think this patient has a UTI? No. I got $1,000 on the table that says no. My second question to you is, What in the heck is a cast? A cast is, look, it's a protein globule. What's a white cell cast? A white cell cast is a cast that's got white cells stuck in it. You know what that means? It means your patient's got two things in the urine and neither one of them ever belongs in there. Protein never belongs in the urine and neither do white cells. You got it? So we don't like the finding of either of those. What's the significance of a white cell cast? Like, what's so bad about that? Well, look, typically we think of something like pyelonephritis or post-streptococcal glomerulonephritis, or maybe a vascular nephritis. Something inflammatory is going on. Does this patient need a urologist? No. What does this patient need? A nephrologist, right? We need somebody whose attention is on kidneys. Look at what we know about casts. White cell casts and red cell casts are always pathological, always. There are two casts that we find that are not so pathological. That happens to be in the case of hyaline casts and in the formation of crystals. And generally in those patients, we tell them, drink more fluids. Drink more fluids. And probably everybody needs to drink more water, right? So I'm going to leave it at this. And I'm going to launch into STIs. You ready? The latest STD guidelines came out in 2010. I expect new ones very soon. Hopefully in 2015, because we have loads of new information about how to manage these things. You will also see that maybe the new name for these is going to be sexually transmitted infections, or STIs. And so here's what I want you to do. There's really no creativity or imagination with STIs. You need to know how to diagnose it and how to treat it and whether or not you need to follow up with it. So I'm going to go through these. If you get all of these, name that STI correct, then I would go study something else before my exam. I would. If you find that you miss a lot of these questions, then this is an area that needs more review, and I've got the information for you following these questions. So let's go through these. You ready? Name that STI. Here's the first one. This screening test is an ELISA. What is it? HIV. It produces a malodorous vaginal discharge. Okay, I'm hearing BV, bacterial vaginosis. What else? How about trick? Oh yeah, trick. What about this one? A DNA probe is used for screening. I'm thinking of two. Not syphilis. Gonorrhea, chlamydia. How about that? Gonorrhea and chlamydia, the two that come to mind first. An RPR is used for screening. What STI? Syphilis, right? So RPR, syphilis. What about this one? An FTA, fluorescent treponemal antibody, MHATP, treponema pallidum, are diagnostic tests for this STI. What's treponema? Syphilis, exactly, yeah. So you'll see an FTA-ABS or an MHATP diagnostic for syphilis, right? It's a blood test, right? It's treated with 2.4 million units of penicillin IM. Syphilis, y'all sure knew that one. Yep, syphilis, always an early disease. This one is treated with 3 doses of benzathine penicillin spaced at weekly intervals. That's syphilis, but listen, this is late syphilis or of unknown duration, all right? So there's a difference in the way we manage them. This one is associated with a positive whiff test. BV, right? Bacterial vaginosis, BV. The confirmatory test is a Western blot. What is that one? HIV. I'm thinking of 2 on this one. It's treated with metronidazole 500 milligrams twice a day for 7 days. Trick. and BV. Listen, I just had a lady who came in to see me, and she said, Amelie, I had that bad vaginal smell again. She said, I think I got that BV thing again. I said, okay. I said, how many times you had this? She said, I had it just recently, and they gave me a medicine they made it go right away, and I want you to give me that medicine. I said, what's that medicine? She said, it's Flag, F-L-A-G. So I guess you give Flag for this. What drug is it? Flagyl. Okay, good. So I'm thinking Flag might help that, metronidazole. What about this one? The etiologic agent is a virus. HIV. I'm hearing herpes. How about HPV, human papillomavirus? If you consider it an STI, a lot of people do, then that would probably be 3 STDs, right? So viruses. Clue cells are present on saline wet mount. BV, absolutely. This STD produces a discharge. Trick. I'm thinking maybe chlamydia. I'm thinking maybe gonorrhea. I'm thinking maybe BV. There are a lot of things that can produce a discharge, and certainly these are 3 of them, or even 4 of them. Everybody with me? What about this one? An absent or decreased number of lactobacilli. No, not yeast. I'm thinking of, what is it? BV, right? Bacterial vaginosis. BV, bacterial vaginosis. What about this? And a wet prep is used for diagnosis. Trick. BV. Okay. It's treated with a cyclovir, valacyclovir, famciclovir with pretty equal efficacy. Herpes, exactly. This STI could be treated with 2 grams of Flag as a single dose. What would that be? Trick? Maybe associated with involuntary weight loss. What you thinking? HIV. Syphilis. Rashes. Syphilis is a very short list of things that produce palmar rashes or rashes on the soles of the feet. Syphilis is certainly one of them. The lighting is not that great in here, and it is the end of the day. But look, people always say, Emily, what is that? Oh, that's a chancre. What are you thinking of? Syphilis, exactly. Vesicles. Herpes. Painful or painless? Painful. Vesicles? Yep, herpes. This is supposed to remind you a whiff test, in which you should never do. A whiff test should always be done at an arm's length, right? And if it's positive, well, first of all, do you think this is positive? Like, no. Either that or she has a cranial nerve 1 abnormality. What do y'all think? All right, so no, I think it's negative. Listen, don't put anything under your nose. Not even your mother's hot apple pie. Don't put anything under your nose, much less something that comes out of somebody. Which STD? It's usually somebody who says, oh, none. Well, no. But that's a good one. Listen, BV, and here's why. You know the first studies that were done with BV that showed that BV was more pronounced or prevalent in which groups of people? We saw it with a way higher prevalence in people who were sexually active compared to populations of Catholic nuns, where we did see it, but very seldom compared to other groups. So that was some of the very earliest research, BV with the nuns. So thank a nun next time you see them.